Chairperson, respected panelists, and the learned speaker. Welcome to all in today's webinar. Today we'll discuss a very important topic, the newer calcium channel blocker in the management of the hypertension. Today our chairperson, Professor Atiqul sir, rheumatologist and the medicine specialist, President Bangladesh Rheumatology Society. And today our panelist, Professor Dr. Abdul Momen sir, Associate Professor, Cardiology Department, National Institute of Cardiovascular Disease. Dr. AKM Monowarul Islam sir, Associate Professor, Department of Cardiology, National Institute of Cardiovascular Disease. And Dr. Tanvir Islam sir, Associate Professor, Department of Internal Medicine, Bangabandhu Sheikh Mujib Medical University. And today our speaker, Dr. Chairperson, cardiologist and the medicine specialist, Bangabandhu Sheikh Mujib Medical University. We know that the hypertension is a very common and the important disease in our daily practice. And it is highly prevalent globally, including Bangladesh. And progressively increase the number of the hypertensive patients. And the hypertension causes a lot of complications like IST, CKD, stroke, premature death, a lot of things. So the strictly control of the hypertension patient management is the key role for management of the hypertension. I request our speaker, Dr. Chairperson, to present his topic and his presentation.
Am I audible? And the slide is visible? Thank you very much for your introduction. All of us, we know that hypertension is a silent killer. And there is a great talk that I can't change the direction of the wind, but I can adjust my sails to always reach my destination, right? Hypertension is such a problem. We can't cure this, but if we sincerely treat the patient, we can control this chronic disease. We know that it is the most prevalent non-infectious chronic disease worldwide and number one cardiovascular mortality driver, and the most cost-effective disease to treat and the easiest to diagnose.
You did not share the screen. Other things are also visible. You should share the screen.
But you know,
এখন কি দেখা যাচ্ছে স্যার?
হ্যাঁ, এখন ঠিক আছে. This is fine.
Okay, sir. It's my great privilege and honor to present my very important topics in front of such legendary person like Syed Atiqul sir. He's my favorite teacher, and Syed Momen sir, Monowarul sir, and Tanvir sir. So I am very proud to present my topic in this very wonderful session. We know that hypertension is a very common disease in our daily practice, and there is a great talk that I can change the direction of the wind, but I can adjust my sails to always reach my destination. It is a great talk. So hypertension is a very common chronic problem. We can't cure this problem, but we can control by appropriate treatment. And we know that it is the most non-infectious chronic disease worldwide and number one cardiovascular mortality driver, and very easy to diagnose by putting a simple blood pressure cuff into our arm, and easier. Sometimes it is quite easy to treat. We know that globally it is highly prevalent. Around 26% of the world population are hypertensive. Still, lots of population are undertreated and underdiagnosed, and it is highly prevalent and expected that in 2025 the prevalence will be increased to 29%, and it is so culminating that around 10.4 million deaths per year occur this to the hypertension and its related complication. It's we know that is one of the important modifiable risk factor. If we define the hypertension, what do you mean by hypertension? We know that the level of blood pressure at which the benefit of treatment unequivocally outweigh the risk of treatment documented by clinical trial, and most of the trial and guidelines show that blood pressure when systolic more than or equal 140 and systolic more than or equal 90, then it is considered hypertension. Except the American College of Cardiology guideline, where the hypertension is more than 130, and more than 80 millimeter mercury. And their defined category, there is defined that what do you mean by normal blood pressure, when the blood pressure is less than 120/80. Pre-hypertension, sometimes it's considered less than 139 to 130. And again, we can define the stage on hypertension when it is 140 to 159, and stage 2 more than 160 or equal systolic, and diastolic more than equal 100. But according to European Society of Cardiology, again, there is a 5 category: optimal, normal, high normal. And high normal category again define grade 1, grade 2, grade 3, and isolated systolic hypertension. And there is a guideline, International Society of Hypertension, Global Hypertension Guideline. I think that they precisely define hypertension in a very simple way: normal blood pressure, high normal, grade 1, and grade 2. So before sealing a patient into hypertension, we have to measure blood pressure very precisely and very meticulously, very sincerely, because somebody, if they know that you are hypertensive, they are very much reluctant that no symptom, then why are considered hypertension? Actually, it is a very less symptomatic. So sometimes patient is not interested to get this source of treatment. So before measuring the blood pressure, I want to show the slide that how different circumstances enhance the false elevation of blood pressure. Like if a person does not sit comfortably with arm rest and back rest, there is a level of, sometimes there's some sorts of increase of blood pressure can happen. Like if there is no leg support, then 5 to 10 millimeter mercury can increase the blood pressure. So ideal condition is that patient should be seated comfortably, leg should be rest in the floor, back should be rest, and arm should be rest on the table, and there is no cloth, tight cloth into the arm, and patient should be less, no exercise or taking of caffeine or smoking within the 30 minutes. Patient should be relaxed within 5 minutes. His bladder must be empty, and we should measure consecutive 3 measurements on minutes apart. If the first reading is less than 130/80, next 2 measurement is not needed. But sometimes we have to measure the blood pressure into 2 arms. And if the feature suggestive of postural drop by according to history, then we have to measure the postural drop sometimes. After meticulous measurement, we have to check the proper history and examination regarding, first of all, blood pressure, the time of onset, any prescribed medication he or she is taking, any positive family history, any positive family history of premature coronary artery disease, regarding risk factor, any other risk factor associated or not, like diabetes, CKD, dyslipidemia. We have to assess the overall the cardiac risk through the different scoring system, like we know the Framingham risk score system. And we have to consider the sign symptom of hypertension and coexisting illness. We have to also address the any features of secondary hypertension, though previously it is noted that the primary cause usually 95%, but we are finding that the hyperaldosteronism is one of the important cause of resistant hypertension. So we have to address this issue. And through the detailed physical examination, including fundoscopy, actually in the first visit, we have to sincerely, by taking the patients, we have to taking the detailed history examination and meticulous measurement. Then we have to go for some routine investigation. First of all, we have to do some basic investigation like electrolytes, especially sodium and potassium, baseline creatine with estimated GFR, lipid profile, fasting blood sugar, including HbA1c sometimes needed, urine RE to see the proteinuria or hematuria, 12B DCG to see any arrhythmia, left ventricular hypertrophy or ischemic heart disease. Then further investigation or additional investigation like or ultrasonogram whole abdomen, ACR, or uric acid. It will guide by checking the history and examination finding. We have to assess the risk, whether the patient is high risk, moderate risk, or low risk. And according to this will further guide for treatment purpose. We have to sometimes consider whether the patient is taking any ancillary medication that may exert the blood pressure, like NSAID, steroid, OCP, antidepressant, acetaminophen, and other drugs that causing the elevated blood pressure. After all the measure, we have to consult the patient that life is beautiful. If you take the hypertensive medication properly, your life will be very fine. You will be freed of lots of complications like stroke and other cardiovascular disorder. So we have to counsel the patient very sincerely. And that is our aim, that we have to, our target is the good control of blood pressure. We address the comorbidity and taking the measure accordingly. We have to prevent the complication. We ensure the good adherence, ultimately, we encourage the patient a healthy living. First of all, non-pharmacological management. We know that there is some parameter like salt reduction. According to the latest guideline, it is estimated that ideally less than 2 grams of sodium chloride should be taken. And some guidelines say less than 5. Healthy diet, all of us, we know that DASH, dietary approach to stop hypertension, which include lots of fresh fruit, vegetables, and polyunsaturated fatty acid. Healthy drinks should be advocated, like any sorts of sugary drinks should be avoided. Weight reduction, particularly in our subcontinent, abdominal obesity is a very growing concern that leads to diabetes and other lots of complications. And it is according to guideline, in case of male, the abdominal circumference should be less than 90 centimeter, and in case of female should be less than 80 centimeter. Then we have to advocate regarding smoking cessation, regular physical exercise. We know that at least 30 minutes per day or more than at least 150 minutes per week. And regarding stress, we know that during COVID period, we undergone a huge stressful condition that leads to the different sorts of complication, depression, and increasing blood pressure. And recently guidelines suggest that we have to reduce the exposure of air pollution. We know that Dhaka is a very important city for a big city for air pollution. So we have to address this sorts of issue. And in nature, we easily find that a very small amount of chicken broth that carries around more than 1,000 milligrams salt. So we should advocate regarding the salty diet, that not more than taken. And then come to pharmacological management. Before going to pharmacological management, we have to address how much blood pressure of the patient had. If a patient has high normal blood pressure, if there is no risk factor, no target organ damage, then we have to advocate that you can carry on lifestyle modification for 3 to 6 months. Then we have to reassess the patient again. And if the patient had already some risk factor or very existing coronary artery disease or the other target organ damage, then we have to advocate the treatment. And in case of grade 1 and grade 2, we, according to guideline, we have to treat the patient by drugs along with the lifestyle modification. What's our target? Generally, our target is less than 140 by 90 millimeter mercury, provided that treatment is well tolerated. If the patient can continue the treatment with good tolerance, then our target should be less than 130 by 80 millimeter mercury. This was class 1 recommendation. If the patient is less than 65 millimeter mercury, then target should be little bit tight. The systolic blood pressure should be less than 120 to 129. And in case of age, if it's more than 65 or more, then it will be to some extent it is reluctant. Systolic blood pressure can be considered 130 over 139 millimeter mercury, provided that he had no target organ damage. This is a very simple algorithm that initially we have to take the single pill combination with combined low dose combination. Actually, if our target level is resides more than 20 millimeter mercury systole and diastolic more than 10, then we can consider this very good combination of drug. There's a lots of advantage of combination, like it improves blood pressure and increase the compliance of the patient. Target or blood pressure can very easily obtain. So single pill combination is a very good approach. Actually, initially we have to prescribe ACE inhibitor or ARB with calcium channel blocker, long-acting calcium channel blocker, preferably the amlodipine or cilnidipine or levoamlodipine or diuretics. In stage 2, if the patient's condition is not improved, then again we can add the ASC or diuretics, especially thiazide diuretics or thiazide-like diuretics. And in case of step 3, which is regarded as resistant hypertension, we have to add the spironolactone. Sometimes আমাদের মনোথেরাপি কিছু জায়গায় কনসিডার করার দরকার হয়, যেমন পেশেন্টের যদি লো রিস্ক গ্রেড 1 হাইপারটেনশন এবং ভেরি এলডারলি পেশেন্ট উইথ ফ্রেল পেশেন্ট থাকে, সেই ক্ষেত্রে আমরা মনোথেরাপি কনসিডার করি। আসলে বিটা ব্লকারের একটা রোল আছে যে বিটা ব্লকার ফার্স্ট লাইন হিসেবে কখনো কনসিডারেবল না, আমরা সবাই জানি। যদি ওনার পেশেন্টের কিছু কমপ্লেইং ইন্ডিকেশন থাকে, যেমন পেশেন্টের হার্ট ফেলিওর আছে, পেশেন্টের অ্যানজাইনা আছে, পেশেন্টের পোস্ট এমআই স্ট্যাটাস, পেশেন্টের অ্যারিথমেট লাইক অ্যাট্রিয়াল ফিব্রিলেশন আছে, young female with who is planning pregnancy, then we can consider the beta blocker. This slide actually a little bit clumsy, I will not tell details. According to the comorbid condition, sometimes we have to consider the drug. Then after treatment, we have to monitoring. Actually, you know that monitoring is very much essential. In COVID period, we have find that how much digitalization, digital effect we have feel. And by even telemetry, we can monitor the patient. And though the treatment is individualized, but monitoring should be done very sincerely, not sometimes by coming to the chamber or hospital. Local hospital, local the healthcare provider aছেন বা pharmacist আছে, ওনা যদি এক্সপার্টাইজ থাকে বা এক্সপিরিয়েন্সড হয়, ওনা কিন্তু এটা খুব মেটিকুলাসলি মনিটরিং করতে পারে। যদি কোনো কমপ্লিকেশন বা যদি কোনো ফার্দার ইস্যু, তাহলে টেলিমেট্রির মাধ্যমে কিন্তু আমরা কনসিডার করতে পারি। Then today's topics, the role of calcium channel blocker in management of hypertension. We know that calcium channel blocker is actually two types: dihydropyridine calcium channel blocker and non-dihydropyridine calcium channel blocker. And dihydropyridine calcium channel blocker from that, amlodipine and nifedipine are most commonly used. And nowadays, levoamlodipine we are also using this drug. And diltiazem verapamil can be used if the patient tachycardia or some other problem exists. Before choosing a drug, sometimes we have to consider some things like the drug should be cost effective, good control of blood pressure within 24-hour coverage, well tolerated হবে এবং পেশেন্টের জন্য কমফোর্টেবল, এমন একটা ড্রাগ চাই আর কি। অ্যামলোডিপিন ইন কেস এই ক্ষেত্রে খুবই ভালো একটা ওষুধ, কিন্তু দেখা যাচ্ছে যে অ্যামলোডিপিনের যে একটা সাইড ইফেক্ট পেরিফেরাল এডিমা হুইচ ইজ এনকাউন্টার্ড অ্যারাউন্ড 8% অফ দ্য পপুলেশন, সেটার জন্য আসলে অ্যামলোডিপিন ধীরে ধীরে পিছায় যাচ্ছে। বাট ইটস এ ভেরি গুড ড্রাগ যদি পেশেন্ট টলারেট করতে পারে এবং দিস ক্লাসিক ইফেক্ট যদি পেশেন্ট যদি অ্যাকসেপ্ট করে নিতে পারে আর কি। আমরা সবাই জানি যে অ্যামলোডিপিন একটা রেসিমিক মিক্সার অফ আর এবং এল এর কম্বিনেশন। এস আইসোমার যেটা এল টাইপ অফ ক্যালসিয়াম চ্যানেল ব্লকার বলা হয়, যেটা ক্যালসিয়াম ইনফ্লাক্সটা প্রিভেন্ট করে ইন ভাস্কুলার স্মুথ মাসেল এবং কার্ডিয়াক মাসেলকে, সো রিজাল্টিং ইন vasodilatation that causing the decrease the peripheral decrease the blood pressure. And আর যে রেসিমিক মিক্সারটা আছে সেগুলো নাইট্রিক অক্সাইড মেডিয়েটেড পেরিক্যাপিলারি vasodilatation করে, অ্যাকচুয়ালি এটা ইডিমা করে, কিন্তু এর কোনো বেনিফিশিয়াল ইফেক্ট নাই আর কি। যার জন্য যেটা অ্যামলোডিপিনের একটা সাইড ইফেক্ট হচ্ছে ইডিমা, লেগ ইডিমা। এটার জন্য বাজারে একটা নতুন ওষুধ আমরা ইদানিং দেখেছি যে এসেছে, লিভোঅ্যামলোডিপিন, যেটা এস আইসোমার অফ লিভোঅ্যামলোডিপিন যেটা ইউজ করা হচ্ছে। সেটা শুধুমাত্র দেখা যাচ্ছে যে এস আইসোমারটা যেটা এল টাইপ অফ ক্যালসিয়াম চ্যানেলকে ব্লক করে এবং আর আইসোমার না থাকার জন্য এটা খুবই পটেন্টলি উইদাউট এনি সাইড ইফেক্ট রিগার্ডিং পেরিফেরাল এডিমা এটা খুব ভালো অ্যাকশন করছে আর কি। So if we see this slide that compare the two pictures simultaneously, we'll find that levoamlodipine, this patient is man is exhausted by taking this drug because sorts of তার মাথায় ঢুকে গেছে যে ইডিমা তার জন্য খুবই কাম্পারসাম sometimes এটা। আর levoamlodipine like a superman, সেটা হচ্ছে লো ডোজে খুবই পটেন্ট এবং পাওয়ারফুল অ্যান্টি হাইপারটেনসিভ শো করছে, পেশেন্টের জন্য খুবই ভালো ফিল করে, ইভেন ইট ইজ চাইল্ডহুডের জন্য সেফ। So, Honorable Chairperson and respected panelists, from our presentation, today's message is that the hypertension is a very common disease, chronic disease that is extremely highly prevalent, and we know that is a modifiable risk factor, and we have to sincerely address this condition when we come across to a patient. And treatment should be individualized, judicious, rational, keeping in the mind all the side effects and regarding the safety. So safer drug with better efficacy and less side effect ensure good compliance, we have to keep in mind. So again, thank you very much for your patient sharing.
Thank you, Speaker Dr. Charan Singh, for your excellent presentation. Sir, Atiq sir, আমরা আসলে শুরু করে দিয়েছিলাম, রাত হয়ে গিয়েছে তো।
না না, খুব ভালো করছো, খুবই ভালো। কোনো ই করার কিছু, অস্বস্তি বোধ করার কিছু নাই। আমি মিস করিনি আসলে।
জি স্যার, জি স্যার। স্যার যেটা হচ্ছে স্যার, এখন আমরা স্যার প্যানেলিস্ট স্যারদের কাছে চলে যাব। প্রথমে যাচ্ছি স্যার ডক্টর আব্দুল মোমেন স্যারের কাছে কিছু বলার জন্য। স্যার
Thank you, Ishita, for your introduction. Atiq sir, assalamu alaikum sir. আমি আপনার স্টুডেন্ট ছিলাম স্যার, হয়তো খুব
Thank you very
আমি
much.
আছি অ্যাসোসিয়েট প্রফেসর হৃদরোগ হাসপাতালে স্যার।
আচ্ছা, thank you, welcome.
Regarding hypertension is a very prevalent and common problem day-to-day practice, but one thing we must appreciate that the measurement of blood pressure is a crucial one. If we take the blood pressure in hanging hand without support or arm, it will increase the blood pressure by 5 to 10 millimeter. If we measure the blood pressure without back support, it will also increase the blood pressure. So it is very important, and there should be a special chair in the clinic for measuring the blood pressure, supporting the hand and supporting the back. And patient and the doctor should not talk during the blood pressure measurement, because it is very important. And measurement of blood pressure, the first measurement should be discarded, the second and third should be averaged. And initially we should measure the blood pressure in both arms. And the postural hypotension should also be tested for the first time if the blood patient is more than 50 years or 60 years and patient is diabetic. For this should be routine. We should measure the postural blood pressure. And regarding the treatment and diagnosis, we should always do the serum electrolyte and urine examination routinely for all hypertension patients, especially for the first time, because many of our patients have active urinary sediments that may be a glomerulonephritis. We can prevent the kidney damage if we take early measurement, and many of them has potassium level is low. So this will indicate some secondary causes of blood pressure, and the treatment strategy will also guided by serum potassium level. And the lifestyle modification is very important. I always mention that 3 things. 1, decrease salt intake, physical exercise 40 minutes a day, and weight reduction 3 to 5 kg. These 3 combination can reduce the blood pressure in an amount that can a medication cannot do this. So this is very important. 5 to 10 millimeter pressure can be reduced by this physical measurement. So every patient should have a customer should have informed it, and we should have some counseling for this reason. So, and regarding the presentation of Dr. Choi, he's always a good presenter and very informative presentation. And regarding the long-acting amlodipine, levoamlodipine, the edema is less. But amlodipine is a very, very important tool in the management of high blood pressure, because it is a very strong drug, but some side effects sometimes bother us. And my last talk on the regarding if we combine the 3 drug with AC inhibitor or ARB, amlodipine, calcium channel blocker, and diuretics, the pressure is not under control. We should always try spironolactone. It is very important, because many of the spironolactone should be tried before any other drug tried, but it is not in our practice. Spironolactone as an antihypertensive is a very uncommon thing in our community so far. So it is very important to try spironolactone before going to other combination. Thank you very much. Thank you, Dr. Chauhan, and everyone.
Thank you, sir. Thank you, sir, for your nice elaboration. আমি স্যার এখন চলে যেতে চাই ডক্টর AKM Monowarul Islam স্যারের কাছে। স্যার কি আছেন আমাদের মাঝে?
আছি।
হ্যাঁ স্যার, আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম। Thank you, Dr. Shita. And also I like to pay my regards to Professor Atiqul sir. Actually, he is the teacher of almost all the postgraduates of our time and beyond.
Yes, sir.
So, Assalamu alaikum, sir.
Alaikum assalam.
Today's topic is a very time-worthy topic, and you know that just within 2 weeks, World Hypertension Day is ahead. So we all should be aware of hypertension. And like other nations in Bangladesh, the hypertension is also very prevalent. Maybe our 25% of the adult population is hypertensive, even maybe more if we use the conservative definition of hypertension. Right now, latest guidelines for the treatment of hypertension are available in our hand. And after more than 1 decade, WHO has published a new hypertension guideline. And this was available a few months back. And at the same time, another guideline available from the US Preventive Service. And these 2 guidelines are among the latest 2 guidelines. And before that, the Canadian Cardiovascular Society has published a guideline. The main theme of the guidelines are like that advocated by the International Society of Hypertension and also the ESC. So all these hypertension guidelines advocate in the same voice that hypertension should be adequately treated, and just single pill combinations are the preferred pharmacotherapy right now. And the drugs that already have been discussed, and Dr. Momen has also said, they are the first line drugs. And one drug in our practice, I often recognize that is underutilized, and that is spironolactone. That should be given in appropriate attention and should be used before declaring a patient that he or she is having resistant hypertension. I like to highlight some important information regarding today's main theme, that is the calcium channel blocker in the treatment of hypertension. We all know that calcium channel blocker is a very commonly used and very popular drug for the treatment of hypertension. And the unique advantage that has been recognized by the latest guideline from the WHO is that if you are going to prescribe medicine in a newly diagnosed hypertension patient, and if you are not having the scope or time to have some investigations, in that case, probably it is safer to start calcium channel blockers in absence of any other investigations or like these things, because this drug is the very safer one, even in presence of renal failure or hepatic impairment or other comorbidities. So this is very important one. One interesting just Cochrane review that has been available in January this year, the information is that if we compare calcium channel blocker with all other antihypertensive drugs available right now, the theme is that there is no difference in all-cause mortality. I am telling about treatment of hypertension, not other comorbidities or things. So there is no difference between calcium channel blocker and other available antihypertensive drugs whenever we are considering the all-cause mortality. But diuretics are better than calcium channel blockers for reduction of total CV events, cardiovascular events, and also congestive cardiac failure. Calcium channel blockers, when compared to beta blockers as an antihypertensive, calcium channel blockers are better in reducing the total cardiovascular mortality. Calcium channel blockers are better than ACE inhibitors whenever the stroke prevention is concerned. And these calcium channel blockers are better than angiotensin receptor blockers whenever we are thinking of prevention of myocardial infarction or heart attack. But calcium channel blocker plays a worse role whenever we are thinking of just congestive cardiac failure. So calcium channel blocker is lagging behind the ACE inhibitor or ARB whenever congestive cardiac failure is concerned. So overall, calcium channel blocker is a very good one, good hypertensive medicine, and also very popularly used, as I have already mentioned. The main drawback is that there are some swelling of the legs or the edema, non-pitting edema that is often experienced. And one of the solution of this edema is that just we can change it to the left amlodipine, or sometimes we can reduce the dose. Or another very important practical way to reduce the calcium channel blocker induced edema is to combine it with AC inhibitor or ARB. In that case, the incidence of leg swelling may be reduced. And interestingly, diuretics had got almost no role in prevention or relief of the amlodipine induced leg swelling or the calcium channel blocker induced leg swelling. So if we just pay attention to these practical things, this is a very good antihypertensive drug, and probably in the future decades we are continue using these first line drugs as antihypertensive drugs. Thank you all.
Thank you, sir. অসংখ্য ধন্যবাদ স্যার আপনাকে খুবই সুন্দর করে স্যার বলার জন্য। আমি এখন চলে যাব ডক্টর মোহাম্মদ তানভীর ইসলাম স্যারের কাছে তার বক্তব্যের জন্য।
Thank you, Dr. Ishita, respected chair of this session, the most talented and charismatic teacher of our time. And as for Dr. Monowarul, it is unnecessary to tell that I am his teacher because we all are teachers. So I can assume that everyone can are his students. Okay, so I'm amused by the presence of my two other acquaintances, Dr. Monowarul and Dr. Momen, who are very much famous in their field. And the problem is, when you are the third panelist, you have very few to add because you had already two other expert panels before you. But I like to add that these calcium channel blockers are in this market for almost 40 years. And with the advent of science, we are going to observe more and more newer form of these drugs. But the parent drugs is almost always there. So amlodipine, after the ASCOT and the value trial, it has been proven that the amlodipine has excellent efficacy and also cardioprotective effects. But the problem with amlodipine was some forms of leg edema, which have already been discussed as we can overcome by using the newer drugs like levoamlodipine. But the basic form of the treatment or the prototype of treatment states that we are going to use the calcium channel blockers, the dipeptides, and preferably the long-acting ones like amlodipine or levoamlodipine. So these drugs are also cost-effective, and also I like to add that these are good for the elderly population and also the special population. So we have lots of added effects by calcium channel blockers. But today's presentation was mostly for introducing us towards a newer form of amlodipine, that is the levoamlodipine, can save us from some of the side effects of amlodipine, which are very commonly present in our day-to-day practice. So I would like to emphasize that in more and more advance of the treatment, we should not forget that every patient should be counseled about the lifestyle modification regarding hypertension, because it is cost effective, it is very vital, and it is the primary thing that we have to do. So alongside the newer treatments, we have to educate the patient regarding the lifestyle modification. I am extremely moved by the excellent presentation of Dr. Charan. I really like to congratulate him, and I will enjoy his every speech onward. So thank you very much. Thank you very much, Dr. Ishita, for giving me the opportunity to talk something in front of these great panels. Thank you.
Thank you, Dr. Tanvir Islam, sir. স্যার আমি এখন চলে যাব আমাদের চেয়ারপারসন স্যারের কাছে, প্রফেসর সৈয়দ আতিকুল স্যারকে কিছু বলার জন্য।
Okay, thank you very much. Actually, I would thank Dr. Charan for very nicely preparing the lecture and for his very brilliant presentation. Charan was one of my most favorite students, and the panelists are also my favorite students, like Tanvir, Momen. They're my very favorite students. So, in fact, whenever the issue, in fact, I have been somewhat isolated, detached from the management of hypertension. And I should say that, I am lagging behind because I don't keep myself updated with the changes in the concepts in the management of hypertension. But even though I have certain observations, on the basis of those observations, I can say that certain mistakes which we should hate to see. And I shall enumerate some such mistakes. Firstly, the diagnosis of hypertension in a patient without target organ damage, it's a very difficult issue. Sometimes the blood pressure rises due to anxiety. Sometimes it may rise due to acute anxiety also, and there are many other factors that already I think Chayan has already explained those things. And if we measure the blood pressure during such circumstance, we may label the patient falsely as a patient with hypertension, and many patients are given antihypertensive drugs on the basis of such misinterpretation. I would say a mistaken diagnosis of hypertension that is not rare in our community. That is, I would say rather, that is quite common. The second mistake is, I often find that in our many patients are taking antihypertensive on the basis of high blood pressure. That's okay. But age is 25, 26, whenever we come across a young patient with hypertension, we must exclude secondary hypertension. Even it is said that, in patients without family history of hypertension, essential hypertension, even in patients with age between 30 and 40, we should be suspecting very strongly the possibility of secondary hypertension. Secondary hypertension is common, that is not rare, as thought by particularly what Chayan has shown. Drugs causing hypertension, the list is much bigger than Chayan has shown. It was not possible to show all the drugs, and we must look at the drugs, whether there is any drug that may cause hypertension, and we have to, if possible, we have to change those drugs. And there are also many other common causes of secondary. CKD is also an important and overlooked cause of secondary hypertension. Then I find that, the third grave mistake is failure to take a shared decision. For the management of hypertension, shared decision means you have to give education to the patient, and we have to convert our patient into a knowledgeable partner of decision making. The decision should come from the patient. We should not impose the decision. Actually, আমি বলবো যে আমাদের দেশে আমাদের ডাক্তারদের বেশিরভাগেরই অ্যাটিটিউডের মধ্যে একটা ফল্ট আছে। আমরা সবাই মনে করি যে আমরা ভগবানের বেদিতে বসা মানুষ, আমরা হুকুম করব এবং আমাদের রোগীরা তামিল করবেন। সেই যুগ কিন্তু অচল হয়ে গেছে। এখন ডেমোক্রেসির যুগ। এখন কিন্তু আমাদের পেশেন্টের সাথে শেয়ার করতে হবে, পেশেন্টকে এডুকেট করতে হবে, এবং পেশেন্টের অপিনিয়নটা নিয়েই আমাদের ডিসিশনটা দিতে হবে। কিন্তু আমি দেখি যে এটা আসলে আমার মনে হয় যে এই অ্যাসপেক্টটা এটা অত্যন্ত ইম্পর্টেন্ট particularly for maintenance of compliance and for successful achievement of the target. এই যে আমরা বলবো হাইপারটেনশন আমাদের টার্গেট আছে, আমাদের তো টার্গেট অ্যাচিভ করতে হবে। এবং আমি বলবো এটা একটা মিস্টেক যে আমরা টার্গেটটা কখনো খেয়াল করি না। একটা নির্দিষ্ট সময় পর পর যে প্রেশারটা টার্গেট, আমি দেখি যে একজন রোগী একই প্রেশার একই ওষুধ পাচ্ছেন 5-6 বছর ধরে, ওনার প্রেশারটা কখনোই টার্গেটে পৌঁছায়নি। সবসময় প্রেশারটা থেকে যাচ্ছে 145/95 একটা লেভেলে, টার্গেটে কখনোই পৌঁছায়নি, এবং তার জন্য কিন্তু ধীরে ধীরে টার্গেট অর্গান ড্যামেজ গুলো জড়ো হচ্ছে। কিন্তু আমরা কখনোই টাইট্রেট করে সেই ওষুধটা বাড়াইনি। এটাও কিন্তু another mistake. Actually, I have to actually this is also for my learning. As far as I know, thiazides are a bit I would say some sort of discarded. Rather, we should more switch to thiazide-like diuretics like indapamide and chlorthalidone. Thiazides are nowadays not very much preferred, just because of 3 major side effects. One is erectile disorder, then electrolyte imbalance, and hyperuricemia. These are the 3 conditions for which thiazide, and all these conditions are less common with thiazide-like diuretics, and that's why they are preferred. And what should be the interval for increasing? I said that there are some doctors who never increase the dose in a patient in whom the target has not been achieved. On the other hand, There are some doctors who are very anxious about the target and ask the patient to come every week. And if the pressure is not controlled, they increase the dose, and it may lead to what is called decapitation. So actually, what is the ideal interval? The ideal interval is 1 month. We should titrate patient at the blood pressure, and we should titrate the treatment at 1 month interval unless the patient has got severe hypertension. So that is also, I would say, another mistake that I still to see made, though maybe wrongly, because I am detached and I am lagging behind. And what should be the timing of giving antihypertensive drugs? Nowadays, we all know that there are combination pills. They're quite good. They're effective. They're safe. But if the combination, actually there is one thing, that there is nocturnal dipping of blood pressure. By the end of night, blood pressure normally falls by approximately 15% from the daytime hypertension, daytime blood pressure, and failure of this fall by 15% or at least 10% is, say these patients are labeled as non-dippers, and this non-dipping or a higher pressure at the end of night or in early morning, correlates very strongly with the risk of stroke. Whenever we talk about the treatment of hypertension, we have to keep in mind prevention of stroke. This is very much important because, the relation is linear. Blood pressure, the magnitude of high blood pressure, correlates very nicely with the, percentage of stroke in this group of that cohort. It doesn't correlate that strongly with myocardial infarction. So we have to think, and, this stroke risk correlates quite strongly with late night hypertension or early morning hypertension. So it is said that it is good to, in one Spanish trial that was quite big trial, in that trial it was found that, the risk of...
This is Hygia chronotherapy trial in 19,000 patients in Spain.
Exactly.
Morning and night. All the antihypertensive, including the diuretics, are given in the night, and in the long term, 6 years follow-up, so that the stroke, myocardial infarction, and cardiovascular mortality is lower. Those who are taking the antihypertensive medication at night. So this is very important trials. Hygia chronotherapy trial.
Exactly. In this trial, actually, it was found that, by shifting the antihypertensive drugs from morning to night, reduce the risk by 35%. It was a very great reduction. That was that is what is very much important. So actually, if a patient is getting 2 drugs, we shall have to give at least 1 drug at night. If the patient is disturbed by nocturnal nocturia, micturition, then we can put the diuretic in the morning, but non-diuretics at night. That is also that can be done. Many of the patients cannot tolerate diuretic at night, because I have seen that they wake up for the urge for micturition if they are given diuretic, but diuretics can be given in the afternoon after lunch also. That is also not a bad time. But it is said that at least 1 antihypertensive must be given. That is also another important point. First, you have to remember, the most common mistake is still beta blockers are the first-line drugs in our country, and beta blockers are not first-line drug as per any recommendation. Beta blockers, as Choyan has already mentioned, there are certain conditions in which beta blockers may be given at the first therapy, but it is not generally recommended. Of course, I didn't know one thing. Choyan has said that if the patient is planning for pregnancy, because I always knew that beta blockers are teratogenic, but possibly that has been proven wrong, and now beta blockers are possibly. Am I?
Labetalol.
Oh, labetalol is safe. Yeah, labetalol, of course, it is not beta blocker. It is combined beta blocker. And labetalol is also, underutilized in our country. We often give, combination drugs like, I would say a beta blocker plus an alpha blocker. Alpha blockers are associated with a higher incidence of heart failure. it means, I would say some sort of failure to prevent development of heart failure with antihypertensive drug. That is also another issue. And actually, alpha blockers are inferior to other groups of antihypertensive drugs in that context. So if we think that we have to combine an alpha blocker with a beta blocker, then it is better to switch to labetalol rather than, adding prazosin or doxazosin, these drugs. So this is also another concept I need to cover. And also, I should cover another concept, that is about sleep. Of course, this is not directly related to, to the management of hypertension. It is more related to prevention of myocardial infarction or reinfarction. That is, but it has some relation with hypertension. We divide sleep into two phases. You all know, REM sleep and non-rapid eye movement, or NREM sleep. That REM sleep is again subdivided into two parts. One is called phasic REM, and the other is called non-tonic REM. During the tonic REM phase, blood pressure, pulse rate, these are static. But during phasic REM, there is blood pressure and pulse. They fluctuate very quickly. They fluctuate, and this is the phase of sleep when when a significant portion, I can't say most, any significant portion of myocardial infarction occurs during, I would say this phasic REM part of the sleep. And that's why it is said that, firstly, a nocturnal dose of antihypertensive is very important. And also, when you give beta blockers are good for preventing tachycardia during phasing REM. Beta blockers are no longer popular drugs, but first you should consider. But if for certain conditions we give, beta blockers, and that condition is not daytime palpitation, maybe something else, that is not daytime palpitation, then it is better to give beta blocker at night, because this beta blocker will prevent tachycardia during phasic REM. So these are the things, I used to say, and I thank the speaker, not speakers, because Chairman was the single, and also the panelists. They have contributed largely, and they have, I would say, enriched my knowledge. So I said that I was lagging behind much. I have not gone through the management guidelines for hypertension for at least 10 years. So I'm lagging behind. Last thing I think I read, that was the recommendation of American Society of American Heart Association, ACVD, and 3 American societies. That was in the year 2013. Am I correct?
Yes, sir.
Yes, sir.
For several years, it was very popularly known as 2013 recommendation.
Yes, sir.
And that was the last, recommendation for treatment of hypertension that I went through. 2013, I mean, for 9 years, I am totally at dark. So the panelists and the speaker have greatly enriched my knowledge. I am very much thankful to them. And also I thank, Ishita and organizers of this webinar for inviting to this session, not for, asking me to chair the session, but just to attend. This, attendance in this session has been of great, I would say great utility for me. Thank you, great benefit for me. And with this, I end my talk. Thank you very much.
স্যার আপনাকে অসংখ্য ধন্যবাদ স্যার। আপনার কাছ থেকে স্যার প্রতি মুহূর্তেই আমরা শিখছি স্যার। আপনি যা বললেন স্যার, আপনার সাথেই আমরা স্যার একমত। স্যার আসলে অ্যান্টি হাইপারটেনসিভ স্যার আমরা দিচ্ছি, কিন্তু আসলে আমরা টার্গেটে পৌঁছাতে পারি না, যেহেতু ফলো আপ, কাউন্সিলিং সবকিছু ব্যাপারে একটা ল্যাকিংস থাকে। ফলে স্যার যেটা কমপ্লিকেশন, ক্রনিক কিডনি ডিজিজ, স্ট্রোক, এগুলো স্যার নন কমিউনিকেবল ডিজিজ গুলো আসলে স্যার বেড়েই যাচ্ছে, যেহেতু আমরা হাইপারটেনশনটাকে খুব ভালোভাবে কন্ট্রোল করতে পারছি না। স্যার আমরা ওয়েবিনারে প্রায় শেষ পর্যায়ে। স্যার এখন আমি ভোট অফ থ্যাঙ্কস এর জন্য মোহাম্মদ মাহবুবুর রহমান, গ্রুপ ইনচার্জ ক্রনিক কেয়ার টিম একমি কে ভোট অফ থ্যাঙ্কস দেওয়ার জন্য অনুরোধ করছি।
Assalamu alaikum. Honorable Chairman, Professor Dr. Syed Atiqul sir, our most valued panel of experts, Dr. Abdul Momen sir, Dr. Tanvir Islam sir, Dr. AKM Monowarul Islam sir, and all the esteemed medical professionals who have joined this wonderful webinar through online. It's my privilege to propose a vote of thanks on this occasion. On behalf of the ACME Laboratories Limited Management, I would like to extend a hearty vote of thanks to the speaker, Dr. Choyong Singha sir, for sharing your findings and opinions today with us. Since the beginning of our journey, the ACME Laboratories Limited is working relentlessly to bring forth the latest generic and medical innovation for the aid of our patients of Bangladesh. With the view to that, we have recently launched a very latest calcium channel blocker, which is lev-amlodipine maleate with the name. Our brand LM is just like the originator for your patient's serum-less BP control, as it is formulated with the same salt in maleate form. For a hypertensive patient, physician's main concern is to offer a treatment which is effective to control blood pressure as well as free of side effects. LM is the latest calcium channel blocker, which will undoubtedly serve both the purposes for your patients. Once again, I would like to acknowledge each one of your presences among us. The ACME Laboratories Limited is immensely thankful for the opportunity to work with such esteemed personalities of Bangladesh. We are certainly looking forward to arrange more of such program with you all in coming days. With sincere feelings of gratitude, bidding a very good night to you all. Thank you all.
Thank you, Mahbubur Rahman, for your vote of thanks. Sir, Chairperson sir, speaker, আমাদের প্যানেলিস্ট স্যার, সবাইকে অসংখ্য ধন্যবাদ অত্যন্ত ব্যস্ততার মধ্যে সময় দেওয়ার জন্য। স্যার রাত যেহেতু অনেক হয়েছে, এর জন্য স্যার আসলে আর কথা বাড়ালাম না। আর স্যার সবাই অনেক অনেক ভালো থাকবেন। শুভরাত্রি।
Thank you and শুভরাত্রি।